She limped through the automatic doors of Naval Hospital Camp Pendleton at 0800 hours on a Tuesday morning that promised to be another scorching Southern California day, her left leg dragging slightly behind her right, a canvas messenger bag slung across her shoulder, and absolutely nothing about her appearance suggesting that she was about to rewrite everything the medical staff thought they knew about courage, competence, and the true meaning of service under fire. Before we jump back in, tell us where you're tuning in from, and if this story touches you, make sure you're subscribed, because tomorrow, I've saved something extra special for you. The antiseptic smell hit Casey Monroe like a familiar punch to the gut, bringing back memories she'd spent the last 18 months trying to forget. White walls, fluorescent lighting, the subtle hum of medical equipment, it all transported her back to field hospitals in places whose names were classified and forward operating bases where the difference between life and death was measured in seconds, not minutes. But this wasn't Afghanistan or Iraq or any of the dozen other countries where she'd practiced medicine under conditions that would have broken most people. This was supposed to be safety, recovery, normalcy. Casey approached the reception desk with the careful, measured gait of someone who'd learned to walk again twice in her lifetime. Once as a toddler, like everyone else. Once as a 28-year-old combat veteran whose left leg had been reconstructed with enough titanium to set off metal detectors from 50 feet away. The receptionist, a middle-aged woman with kind eyes and graying hair pulled back in a practical bun, looked up from her computer screen with the professional smile that hospital staff perfected after years of dealing with patients who ranged from grateful to hostile to everything in between. "How can I help you today?" the receptionist asked, her name tag identifying her as Linda Morrison, 15 years of service. Casey pulled a manila folder from her messenger bag and placed it on the counter with the same precision she'd once used to organize surgical instruments in a combat zone. "Casey Monroe, I have an appointment with Dr. Elizabeth Hayes at 0830 hours for follow-up on my leg reconstruction." Linda's fingers moved across the keyboard with practiced efficiency, pulling up Casey's file. Her eyes scanned the screen, taking in the basic information that told only the smallest fraction of Casey's story. 29 years old, honorably discharged, disability rating pending, current address in a small apartment complex near the base that specialized in transitional housing for veterans who were figuring out what came next. "I see you here, Miss Monroe. The doctor is running about 15 minutes behind this morning, but we'll get you checked in and seated in the waiting area." Miss Monroe. Not Captain Monroe. Not even the simple recognition that the woman standing in front of her had once carried a rank that commanded respect from soldiers who trusted her with their lives. Just another patient in the endless stream of people who needed fixing, patching up, or managing until they could function well enough to stop being the military's responsibility. Casey nodded and accepted the clipboard with the forms that asked the same questions every medical facility asked. Insurance information, emergency contacts, current medications, pain levels on a scale of 1 to 10. Nothing about where she'd served or what she'd seen or how many lives she'd saved when the protocols said it was impossible. Nothing about the call sign that had once been whispered in reverence in special operations circles, or the missions that existed only in after-action reports so classified they might as well have been fiction. She found a seat in the waiting area near a window that looked out onto the parking lot, where civilian cars sat next to military vehicles, a visual reminder of the strange liminal space that military hospitals occupied. Neither fully military nor completely civilian, but something caught between worlds, much like the patients they served. The waiting room was populated with the usual mix of active duty personnel, retirees, and family members that filled military medical facilities. A young Marine sat across from her, his dress blue uniform crisp and clean, probably there for a routine physical before deployment. 2 rows over, an elderly man who had to be a Vietnam veteran, based on his cap and the way he carried himself, talked quietly with his wife about their grandchildren and whether he should finally get his hearing aids adjusted. Casey pulled out a paperback novel, something generic she'd picked up at the commissary, and tried to lose herself in a story that had nothing to do with medicine or military service or the weight of carrying other people's pain. But her attention kept drifting to the conversations around her, the casual observations that revealed how people saw the world and where they placed their assumptions about competence and capability. "Excuse me, are you waiting to see Dr. Hayes too?" The voice belonged to a woman about Casey's age, blonde hair pulled back in a ponytail, wearing scrubs that identified her as a nurse. Her name tag read Olivia Wright, RN, and she had the confident bearing of someone who'd found her place in the medical hierarchy and was comfortable with her role in it. "Yes," Casey replied simply, looking up from her book. "I'm Olivia. I work with Dr. Hayes. I couldn't help but notice you're reading The Hot Zone. Kind of intense medical reading for someone who's just here for an orthopedic follow-up, don't you think?" There it was, the assumption that someone sitting in a waiting room with a reconstructed leg couldn't possibly have any reason to read about infectious diseases beyond morbid curiosity. The subtle suggestion that medical knowledge was the exclusive domain of people who wore scrubs or white coats, not patients who happened to pick up books about subjects they might understand better than their caregivers realized. Casey held up the book and glanced at the cover as if she'd forgotten what she was reading. "It was recommended to me," she said neutrally. "Seemed interesting." "Well, just so you know, some of the stuff in there is pretty graphic. Preston doesn't hold back when he's describing what Ebola does to the human body. Might not be the best thing to read when you're already dealing with medical issues." The condescension was gentle, well-intentioned even, but it landed on Casey like a familiar weight. The assumption that she couldn't handle graphic medical content, that her status as a patient automatically made her squeamish or uninformed about the realities of human physiology under extreme stress. If Olivia only knew that Casey had once performed emergency surgery on a soldier whose abdomen had been opened by shrapnel while mortar rounds fell around their position, she might reconsider her assessment of what constituted disturbing medical content. "I'll keep that in mind," Casey said, returning her attention to the book. Olivia lingered for a moment, clearly expecting more conversation, then shrugged and walked away when it became clear that Casey wasn't interested in small talk about her reading choices or her medical condition. Across the waiting room, an orderly named Derek Johnson was restocking magazines and wiping down surfaces with the kind of casual efficiency that spoke to years of routine. He'd noticed the interaction between Casey and Olivia, and as he worked his way closer to where Casey was sitting, he felt compelled to add his own observation. "You know, I see a lot of people come through here reading medical books, thinking they're going to diagnose themselves or understand what's wrong with them better than the doctors do. Usually doesn't work out that way." Derek was the kind of man who'd found his niche in the medical world by being competent at practical tasks while maintaining just enough authority to feel important. He knew where supplies were kept, which doctors had bad tempers, and how to navigate the informal power structures that existed in any large institution. What he didn't know was that the woman he was addressing had once been responsible for making life-and-death medical decisions in environments where the nearest trauma surgeon was hours away by helicopter, and the only resources available were what you could carry in a field medical kit. Casey looked up at him with the kind of patient expression that people developed after years of having their intelligence questioned by people who knew significantly less than they assumed. "I'm sure you're right," she said simply. Derek nodded with the satisfaction of someone who just dispensed valuable wisdom to someone who clearly needed it. "These doctors went to school for 8, 10 years to learn this stuff. No shame in leaving the diagnosing to the professionals, you know?" "Absolutely," Casey agreed, her voice giving away nothing about the fact that she'd completed more advanced medical training than most of the nurses in the facility, or that she'd practiced emergency medicine in conditions that would have sent most medical professionals into psychological collapse. As Derek moved on to continue his cleaning routine, Casey returned to her book. But she was no longer reading about viral hemorrhagic fevers in African research labs. Instead, she found herself thinking about assumptions, about the way people saw what they expected to see instead of what was actually in front of them. In her old life, that kind of cognitive blindness could get people killed. In civilian medical settings, It just made for uncomfortable waiting room interactions and the slow erosion of respect that came from being constantly underestimated. The morning stretched on, and Casey waited with the patience of someone who'd learned that most things worth having required waiting for. Around her, the hospital continued its daily rhythm of healing and bureaucracy, staffed by people who were competent and dedicated, but who had no idea that sitting in their waiting room was someone whose medical expertise had been forged in the crucible of combat, and whose understanding of trauma extended far beyond what any textbook could teach. When her name was finally called, Casey stood up, shouldered her messenger bag, and walked toward the examination rooms with the same quiet dignity she'd maintained throughout the morning. Behind her, the waiting room conversations continued, full of assumptions and casual dismissals that revealed more about the speakers than they realized. None of them had any idea that they'd just spent an hour in the presence of someone whose call sign had once been spoken with reverence in operating rooms where the impossible was considered routine, and where the difference between life and death came down to skill, training, and the kind of calm competence that couldn't be taught in medical school. But they were about to find out. Dr. Elizabeth Hayes had been practicing orthopedic medicine for 12 years, and in that time, she developed the kind of clinical efficiency that came from seeing hundreds of patients with similar injuries. Reconstructed knees, rebuilt shoulders, titanium rods replacing shattered bones. The human cost of military service measured in X-rays and surgical hardware. She prided herself on being thorough but practical, addressing her patients' immediate medical needs without getting bogged down in lengthy conversations about how their injuries occurred or what their service had entailed. When Casey entered examination room 3, Dr. Hayes was already reviewing her file on a tablet, scanning through surgical notes and rehabilitation progress reports that told the story of a complex leg reconstruction following what the paperwork diplomatically referred to as combat-related trauma. The medical details were straightforward enough: multiple fractures, extensive soft tissue damage, 3 surgeries to rebuild the tibial plateau, ongoing physical therapy to restore range of motion. "Good morning, Miss Monroe," Dr. Hayes said without looking up from her tablet. "How's the leg feeling today? Any increase in pain, swelling, or limitation in mobility since your last visit?" Casey settled onto the examination table, the paper crinkling beneath her as she positioned herself for what she knew would be a routine check of her surgical sites and range of motion testing. Pain level is manageable, around a 3 on most days. Some stiffness in the morning, but that improves once I get moving. Dr. Hayes nodded, making notes on her tablet. "That's consistent with what we'd expect at this stage of your recovery. Let me take a look at how things are healing." The examination proceeded with professional efficiency. Dr. Hayes palpated the surgical sites, checking for signs of infection or unusual swelling. She tested Casey's range of motion, noting the degrees of flexion and extension with the kind of precise measurement that would be recorded in her file and compared to previous visits to track progress over time. "Range of motion is improving nicely. You're at about 85% of normal, which is excellent progress considering the extent of the initial trauma. How's physical therapy going?" "It's going well. I've been working with a therapist twice a week, and I do the exercises at home every day." "Good. Consistency is key with these recoveries." Dr. Hayes made another note. "I'm going to recommend we continue with the current therapy regimen for another month, then reassess. Any questions about your care plan?" This was the moment Casey had been building toward, the reason she'd requested this specific appointment rather than simply continuing with routine follow-ups. She reached into her messenger bag and pulled out a folder containing several pages of medical literature she'd printed from various journals. "Actually, Dr. Hayes, I've been doing some reading about advanced rehabilitation techniques for complex tibial reconstructions, and I wanted to discuss possibly incorporating some additional modalities into my therapy plan." Dr. Hayes looked up from her tablet with the expression of someone who'd heard a familiar song begin playing. Patients who conducted their own medical research were nothing new in her practice. The internet had made medical information more accessible than ever, and while she appreciated patients who took an active interest in their recovery, she'd learned to be cautious about recommendations from people who lacked the clinical training to properly interpret complex medical studies.
I appreciate your interest in your recovery, Ms. Monroe, Dr. Hayes said with practiced patience, but I want to caution you about relying too heavily on information you find online. Medical research can be very technical, and without the proper context, it's easy to misinterpret results or draw conclusions that aren't supported by the data. Casey opened the folder and pulled out several peer-reviewed articles from journals like the Journal of Bone and Joint Surgery and the American Journal of Sports Medicine. These are specifically about neuromuscular electrical stimulation combined with proprioceptive training for patients with tibial plateau reconstructions. The research suggests that patients who incorporate these techniques show significantly improved outcomes in both strength recovery and joint stability. Dr. Hayes glanced at the papers Casey had laid out on the examination table. She recognized the journal names, respected publications that she read regularly to stay current with developments in her field. But her attention was less focused on the content of the research than on the presumption that her patient thought she knew enough to make clinical recommendations. These are certainly reputable journals, Dr. Hayes acknowledged, but you have to understand that individual studies don't always translate directly to clinical practice. There are factors like patient selection criteria, control group variables, and long-term follow-up data that affect how we interpret and apply research findings. Casey nodded respectfully. I understand that. I'm not suggesting we ignore clinical judgment or established protocols. I'm just wondering if these techniques might be worth considering as supplementary approaches, given that my baseline fitness level was significantly higher than the average patient population in most studies. There it was, the assumption that Dr. Hayes encountered regularly from patients who thought their individual circumstances made them special cases deserving of modified treatment plans. Military patients were particularly prone to this kind of thinking, convinced that their physical conditioning or pain tolerance put them in a different category from civilian patients with similar injuries. Ms. Monroe, I appreciate that you were in excellent physical condition before your injury, but the physiological healing process for bone and soft tissue doesn't really differentiate between military and civilian patients. Your body is responding to the surgical reconstruction exactly the way we'd expect, and the therapy plan we've developed is based on decades of clinical experience with patients who have very similar injuries. Casey felt the familiar weight of being politely dismissed by someone who assumed that her interest in her own medical care was the product of internet research and wishful thinking, rather than any actual understanding of the underlying physiology. She'd encountered this attitude before, in various contexts, and she'd learned that pushing back usually accomplished nothing except to reinforce people's assumptions about patients who thought they knew better than their doctors.
Of course, she said simply, closing the folder and returning the papers to her bag. I just thought it was worth asking. Dr. Hayes made a final note on her tablet and set it aside. I'm going to write you a prescription for another month's worth of the anti-inflammatory medication, and I want to see you back here in 4 weeks to check on your progress. If you experience any increase in pain, swelling, or limitation in mobility before then, don't hesitate to call. Casey accepted the prescription and the follow-up appointment card with the same quiet dignity she'd maintained throughout the examination. She thanked Dr. Hayes professionally and made her way back through the waiting room toward the hospital's main entrance. In the hallway outside Examination Room 3, Olivia Wright was updating patient charts when Dr. Hayes emerged from the appointment. As one of the senior nurses in the orthopedic department, Olivia often served as an informal sounding board for doctors who wanted to discuss challenging cases or unusual patient interactions. How did things go with Miss Monroe?
Olivia asked, looking up from her paperwork. Dr. Hayes shook her head with the weary expression of someone who just navigated a familiar challenge. Another internet expert who thinks she knows better than her medical team. She came in with a folder full of journal articles she'd printed out, wanting to modify her therapy plan based on research she'd found online. Really? Olivia's eyebrows raised in surprise. She seemed pretty quiet when I talked to her in the waiting room, although she was reading that Ebola book, which I thought was kind of intense for someone who's just dealing with an orthopedic issue. They always start with the quiet, respectful approach, Dr. Hayes explained, settling into her desk chair to complete Casey's chart notes. Then they pull out their research folder and start making suggestions about how we should modify our treatment protocols. I've seen it 100 times. Derek Johnson, who'd been restocking supplies in the nearby equipment closet, overheard the conversation and felt compelled to add his own observation. I noticed her too. Had that look, like she thought she was smarter than everyone else in the room. Kept acting like she understood medical stuff better than the people who actually work here. Dr. Hayes nodded. It's frustrating because you want patients to be engaged in their care, but there's a difference between asking informed questions and thinking you can practice medicine based on Google searches and journal abstracts. What kind of articles did she bring? Olivia asked, genuine curiosity in her voice. Something about electrical stimulation and proprioceptive training. Legitimate research, but she completely missed the point about how clinical studies translate to individual patient care. These people read one study that shows positive outcomes and think it applies directly to their specific situation without understanding the selection criteria or control variables. The conversation continued in this vein for several more minutes, with each participant adding their own observations about patients who overestimated their ability to understand complex medical information. It was a familiar topic in healthcare settings, the challenge of managing patients who had access to medical literature but lacked the clinical training to properly interpret and apply it. None of them considered the possibility that Casey Monroe's interest in advanced rehabilitation techniques might stem from something other than internet research and wishful thinking. None of them wondered why a patient with a reconstructed leg would have such detailed knowledge of electrical stimulation or proprioceptive training protocols. And none of them questioned their assumption that her suggestions were the product of amateur medical research rather than professional experience in a field where such techniques are routinely used to get wounded soldiers back into combat-ready condition as quickly as possible. As Casey made her way across the parking lot toward her car, she carried with her the weight of another dismissed conversation. Another moment when her expertise had been politely ignored by people who couldn't see past their own assumptions about who she was and what she might know. But the day was far from over, and sometimes the most important encounters happened when you least expected them. Casey sat in her car in the hospital parking lot for nearly 20 minutes before she finally turned the key in the ignition. The air conditioning hadn't quite caught up with the Southern California heat that was already building toward what promised to be another scorching afternoon, and the steering wheel was hot enough to be uncomfortable against her palms. But the physical discomfort was nothing compared to the familiar weight of frustration that settled in her chest whenever she encountered the polite dismissal that had become such a constant part of her civilian life. She'd known this would happen, had prepared herself for it even. But knowing that people would make assumptions about her capabilities didn't make the reality any easier to accept. In her previous life, when she'd worn the uniform and carried the rank and operated in environments where competence was measured by results rather than credentials, her knowledge had been respected, sought after, sometimes desperately needed. Now, in examination rooms and waiting areas and countless other civilian spaces, that same knowledge was treated as presumption, an overreach by someone who didn't understand her place in the hierarchy. Rather than heading directly home to her small apartment, Casey found herself driving toward the beach. It wasn't something she did often. The crowds and noise usually felt overwhelming after the hyper-vigilant quiet she'd learned to prefer. But today she needed the perspective that came from looking out at something vast and unchanging, something that didn't care about ranks or credentials or the arbitrary ways that people decided who deserved respect and who deserved to be politely ignored. She parked at a scenic overlook where a few other cars sat scattered across the lot, their occupants either napping in the shade or walking down to the water. Casey chose a bench that faced west toward the ocean, pulling her messenger bag onto her lap and extracting the folder of medical literature that Dr. Hayes had so quickly dismissed. The research she'd brought wasn't the product of casual internet browsing or wishful thinking about her recovery timeline. It was the culmination of weeks spent in medical libraries, reading studies that directly related to techniques she'd used in field hospitals where soldiers needed to be returned to duty as quickly as possible. Neuromuscular electrical stimulation, proprioceptive training, accelerated rehabilitation protocols. These weren't experimental treatments she'd read about online. They were tools she'd used to help wounded warriors get back on their feet when conventional timelines meant the difference between a soldier returning to their unit and being medically retired. But explaining that to Dr. Hayes would have required revealing information about her service that she wasn't ready to share, wasn't sure she'd ever be ready to share. The missions were classified. The techniques she'd learned were developed in facilities that didn't officially exist. The patients she'd treated were operators whose injuries couldn't be acknowledged in public medical literature because their very presence in certain countries was a matter of national security. So she sat quietly while medical professionals who'd never worked outside the controlled environment of a hospital explained to her why her understanding of rehabilitation medicine was inadequate, why her questions about alternative treatments revealed her amateur status, why she should trust the experts who actually knew what they were talking about. Casey opened one of the journal articles and read through the methodology section again, her eyes moving across familiar terminology that described exactly the kind of work she'd done for 6 years before the IED that ended her career. The study's conclusions were conservative, cautious in the way that academic medicine demanded. But she'd seen these techniques work in real time, had watched soldiers who should have been looking at months of recovery return to active duty in weeks, their rehabilitation accelerated by approaches that combined cutting-edge technology with the kind of intensive, individualized care that was only possible when resources were unlimited and failure wasn't an option. A jogger passed by her bench, breathing hard in the midday heat, and Casey found herself automatically assessing his gait, noting the slight pronation in his left foot that suggested an old ankle injury, the way he favored his right side in a pattern that indicated compensation for some kind of lower back issue. It was an unconscious habit, the kind of diagnostic observation that had become second nature during years of treating athletes and soldiers who pushed their bodies beyond normal limits. In her old life, she might have stopped the jogger, offered advice about his running form, suggested exercises that could address the underlying muscular imbalances that were probably causing him chronic discomfort. She might have prevented a stress fracture or a more serious overuse injury by sharing knowledge that could help him run more efficiently and with less risk of breakdown. But in her current life, such an interaction would be seen as overreach, presumption. Another example of someone without proper credentials thinking they knew better than the professionals. The jogger would probably smile politely and continue on his way, filing the encounter under strange conversations with random strangers, rather than considering that the woman on the bench might actually know something useful about biomechanics and injury prevention. Casey closed the journal article and returned it to her folder. The research would remain unread by the people who might benefit from it, just as her knowledge would remain unshared in the medical settings where it might actually help patients achieve better outcomes. She'd learned to accept this as part of the cost of transition, the price of moving from a world where expertise was valued to one where credentials mattered more than competence. Her phone buzzed with a text message from her physical therapist, confirming their appointment for the following Thursday.
Sandra Martinez was one of the few medical professionals Casey had encountered who seemed genuinely interested in her patients' observations about their own recovery. She listened when Casey mentioned that certain exercises felt more effective than others, asked follow-up questions about pain patterns and range of motion that suggested she valued Casey's input, rather than simply tolerating it. But even Sandra didn't know the full extent of Casey's background. She saw a motivated patient who was unusually knowledgeable about anatomy and rehabilitation, someone who approached physical therapy with the kind of disciplined focus that suggested military training. She didn't know that Casey had spent years teaching these same exercises to soldiers who needed to return to active duty status as quickly as possible, that she developed modification techniques for patients who were dealing with multiple injuries simultaneously, that her understanding of rehabilitation came from practical experience rather than textbook learning. Casey typed a quick response confirming the appointment, then slipped her phone back into her bag. Around her, the normal rhythm of civilian life continued. Families walking toward the beach, couples taking photos against the ocean backdrop, teenagers playing music from portable speakers while they shared snacks and gossip. All of it so ordinary, so peaceful, so removed from the world where she'd spent the most meaningful years of her adult life. She thought about Ruby Patel, the young medical student she'd noticed in the hospital waiting room earlier that morning. There had been something different about Ruby's energy, a kind of focused intensity that reminded Casey of herself at that age. The girl had been reading from what looked like advanced surgical textbooks, taking notes in the margins with the kind of detailed attention that suggested genuine passion for the material rather than simple academic obligation. In her old life, Casey might have mentored someone like Ruby, shared the kind of practical knowledge that could only be learned through hands-on experience in high-pressure situations. She might have taught her about triage decisions that textbooks couldn't cover, about maintaining composure when every available resource was already committed, and new casualties kept arriving faster than they could be processed. But mentorship required relationships, and relationships required trust, and trust required the kind of honesty about her background that Casey wasn't ready to offer. So Ruby would learn the same way everyone else did, through formal education and supervised practice, and the slow accumulation of experience over years of civilian medical training. Casey stood up from the bench and walked back toward her car, her leg protesting slightly after sitting in one position for too long. The physical therapy was helping, but progress was slower than it had been during her initial recovery. Back then, she had access to resources and techniques that weren't available in civilian settings, and she'd been motivated by the possibility of returning to active duty rather than simply achieving normal function. Now, her goal was more modest. Walking without pain, returning to activities that most people took for granted, finding a way to build a meaningful life in a world that had no particular use for the skills that had once defined her professional identity. As she drove away from the ocean, Casey caught herself planning the rest of her day around the comfortable routines that had become her civilian life. Grocery shopping, meal preparation, an hour of reading before bed. Simple activities that required no special expertise, made no demands on the knowledge she'd spent years accumulating, asked nothing of her except the kind of basic competence that any functioning adult could provide. It was a quiet life, a safe life, and she was grateful for both the quiet and the safety. But sometimes, in moments like this, she couldn't help but wonder what it would feel like to be needed again, to have her expertise valued rather than dismissed, to be seen as someone with something important to contribute, rather than just another patient working through her own recovery. She had no way of knowing that such a moment was less than 24 hours away, or that when it came, it would change everything about how the people at Naval Hospital Camp Pendleton understood the difference between credentials and capability.
Hospitalman third class Gabriel Santos had been working the night shift at Naval Hospital Camp Pendleton for 18 months, and in that time he'd developed the kind of observational skills that came from being the person everyone else forgot was in the room. Night shifts were different from day shifts in any medical facility. The pace was slower, more deliberate, but the stakes could be higher when things went wrong. Fewer staff, less backup, and the kind of cases that couldn't wait until morning. Gabriel had joined the Navy at 19, straight out of high school in East Los Angeles, looking for structure and purpose and a way to serve something larger than himself. Hospital corpsman training had been challenging but rewarding, teaching him the fundamentals of emergency medicine and patient care that had become the foundation of his professional identity. He was good at his job, respected by his colleagues, and genuinely committed to the mission of providing medical care to the men and women who served their country. But Gabriel's real education had come from observation, from the countless hours spent in hospitals and medical facilities where he'd learned to read the subtle signs that separated experienced medical professionals from people who were simply going through the motions. He could identify a surgeon who'd worked trauma cases by the way they approached a patient. He could spot a nurse with ICU experience by how they prioritized tasks during a crisis. And he could recognize combat veterans, even out of uniform, by dozens of small details that most people never noticed. It was 06:30 when Gabriel first saw Casey Monroe walking through the hospital's main entrance, and something about her immediately caught his attention. Not her limp, which was obvious enough that anyone would notice it, not her civilian clothes or her quiet demeanor or any of the surface details that had led his colleagues to dismiss her as just another patient working through her recovery. It was the way she moved through space. Even with the reconstructed leg, even with the careful gait that spoke to months of physical therapy, there was something economical and purposeful about her movement that reminded Gabriel of the special operations medics he'd encountered during his training rotations at Camp Pendleton's trauma center. They moved like people who'd learned that wasted motion could be the difference between saving a life and losing one, who'd internalized the kind of spatial awareness that came from working in environments where situational alertness was a matter of survival. Gabriel was restocking supplies in the orthopedic wing when he overheard Dr. Hayes' conversation with Olivia Wright about Casey's appointment. The dismissive tone was familiar. Medical professionals talking about patients who thought they knew more than their doctors, patients who brought internet research to appointments and questioned established treatment protocols. But something about the description didn't match Gabriel's observation of the woman he'd seen that morning. Dr. Hayes was describing someone who'd brought journal articles about neuromuscular electrical stimulation and proprioceptive training to her appointment, treatments that were standard protocol in military medical settings, but less commonly used in civilian practices. That wasn't the kind of research someone typically found through casual internet browsing. Gabriel had completed rotations at the Navy's premier medical training facilities, including the Special Operations Combat Medic course that was considered one of the most advanced tactical medicine programs in the military. He knew exactly what neuromuscular electrical stimulation and proprioceptive training were used for, and he knew that the people who understood these techniques well enough to discuss them intelligently were usually people who'd used them professionally.
During his lunch break, Gabriel made his way to the medical records department and requested access to Casey Monroe's file. As a corpsman with appropriate clearance working in the orthopedic department, he had legitimate reasons to review patient information, and the records clerk didn't question his request. Casey's file was surprisingly thin for someone with her level of injury complexity. Basic demographic information, surgical notes from her leg reconstruction, physical therapy progress reports, and insurance documentation. But what struck Gabriel most was what wasn't in the file. No detailed service history beyond a notation that she was an honorably discharged veteran. No indication of her military occupational specialty or unit assignment.
No reference to the specific circumstances of her injury beyond the generic designation combat-related trauma. For someone who'd sustained the kind of complex lower extremity injuries described in the surgical notes, the lack of detailed background information was unusual. Most military medical records contained extensive documentation about deployment history, unit assignments, and the tactical situations that led to injuries. The absence of such information suggested either that Casey's service history was classified at a level that required special clearance to access, or that her records had been deliberately sanitized to remove sensitive details. Gabriel had seen sanitized medical records before, during his rotations at facilities that treated special operations personnel whose missions couldn't be acknowledged in standard documentation. The pattern was familiar. Excellent medical care for serious injuries, but minimal background information that might reveal operational details or unit affiliations. He returned Casey's file to the records clerk and spent the rest of his shift thinking about the disconnect between Dr. Hayes' description of an internet-educated patient and the evidence that suggested someone with genuine professional knowledge of advanced rehabilitation techniques. The next morning, Gabriel arrived at work 30 minutes early and positioned himself near the main entrance where he could observe the morning patient traffic. He wanted another look at Casey Monroe, wanted to see if his initial impression had been accurate or if he'd been reading too much into subtle behavioral cues that might have simpler explanations. Casey arrived at 08:15, 15 minutes before her follow-up appointment with the physical therapy department. Gabriel watched her walk through the entrance with the same purposeful economy of movement he'd noticed the previous day. But this time, he was looking for different details, the kind of markers that separated people who'd received advanced medical training from people who'd simply been patients in medical facilities. She paused at the information desk to confirm the location of the physical therapy department, and Gabriel noticed how her eyes automatically scanned the hospital directory, not just looking for her destination, but taking in the overall layout of the facility. It was the kind of comprehensive situational awareness that combat medics developed, the habit of understanding your environment well enough to navigate it efficiently under any circumstances. When she walked toward the physical therapy wing, Gabriel saw her pause briefly outside the emergency department, her attention drawn by the sound of an ambulance siren in the distance. Most people would have glanced toward the sound and continued walking. Casey stopped, oriented toward the approaching emergency vehicle, and seemed to be automatically calculating response times and resource allocation in a way that suggested she'd been on the other side of similar situations. Gabriel made a decision. During his break, he walked to the physical therapy department and found Sandra Martinez, Casey's physical therapist, updating patient charts in the small office adjacent to the main treatment area. "Sandra, can I ask you about one of your patients? Casey Monroe, the veteran with the tibial reconstruction?" Sandra looked up from her paperwork with interest. "Casey? She's one of my most dedicated patients. Why do you ask?"
I'm curious about her background. Has she mentioned anything about her military service, her medical training? Sandra considered the question carefully. She's never been specific about what she did in the military, but she has an unusual understanding of rehabilitation medicine. She asks very sophisticated questions about muscle recruitment patterns and proprioceptive feedback. Sometimes I feel like I'm treating a colleague rather than a patient. What kind of questions? Last week, she asked about modifying her exercises to address compensatory movement patterns that might develop if we focus too heavily on isolated strength training without considering integrated functional movement. That's not the kind of question most patients ask, even patients who are very engaged in their recovery. Gabriel nodded. Has she ever mentioned working in medical settings? Not directly, but there are little things. She knows medical terminology that most people wouldn't know. She understands anatomy in a way that suggests hands-on experience, not just textbook knowledge. And she has this way of observing other patients that reminds me of the way medical professionals assess people. Not obviously, but like she's automatically cataloging information about their condition and movement patterns.
Gabriel felt his suspicions solidifying. Sandra, I think there might be more to Casey's background than we realize. I've seen her medical file, and it's unusually sparse for someone with her level of injury complexity. I'm wondering if her service history might be classified. Sandra leaned back in her chair, considering this possibility. You know, that would actually explain a lot. She has knowledge that suggests significant medical training, but she's never mentioned working as a medic or corpsman. I assumed she'd just done a lot of research about her own condition. But now that you mention it, her understanding seems too comprehensive and practical for someone who learned everything from patient education materials. Would you be willing to help me figure out who she really is? Sandra was quiet for a moment, weighing the ethical implications of investigating a patient's background. Gabriel, I appreciate your curiosity, but we need to be careful about patient privacy. If Casey wanted us to know more about her service history, she'd tell us. I understand that, but I think there's something important we're missing, and I think it might affect the quality of care she's receiving. If she has advanced medical training that could inform her treatment plan, shouldn't we know about that? Before Sandra could respond, their conversation was interrupted by the sharp electronic tone of the hospital's emergency alert system. The voice that followed was calm but urgent, the kind of announcement that immediately focused everyone's attention on potential crisis situations. Code Silver Emergency Department. Code Silver Emergency Department. All available medical personnel to ED immediately. Code Silver meant mass casualty event, multiple patients requiring immediate emergency care, usually the result of a major accident or incident that had overwhelmed the normal emergency response capacity. Gabriel and Sandra exchanged glances, both understanding that their conversation would have to wait while they responded to whatever crisis was unfolding in the emergency department. But as they hurried toward the ED, Gabriel couldn't shake the feeling that they were about to discover something important about Casey Monroe's background, something that would change how everyone at the hospital understood the quiet woman who'd been so consistently underestimated by the people who thought they knew what expertise looked like. The crisis was about to reveal who Casey really was, and Gabriel had positioned himself to recognize the truth when it emerged.
The emergency department at Naval Hospital Camp Pendleton transformed into controlled chaos within minutes of the Code Silver announcement. A tour bus carrying 32 retired veterans to a memorial service had collided with a commercial truck on Interstate 5, resulting in multiple casualties with varying degrees of trauma. The initial reports indicated at least 15 patients requiring immediate medical attention, with several in critical condition. Casey had been in the physical therapy department when the announcement echoed through the hospital corridors. She'd been working through her prescribed exercises on the parallel bars, focusing on the careful progression of weight-bearing activities that would eventually restore full function to her reconstructed leg. Sandra Martinez had stepped away to respond to the emergency call, leaving Casey alone in the rehabilitation gym with instructions to continue her routine and check out at the front desk when she finished. But Casey couldn't concentrate on her exercises. The familiar sound of organized medical chaos, rapid footsteps, urgent voices, the electronic beeping of medical equipment being moved at speed triggered responses that had been dormant for months. Her body automatically shifted into a state of heightened alertness, her mind beginning to process information and prioritize actions in ways that had nothing to do with her current status as a patient working through her own recovery. She could hear the ambulances arriving, the distinctive sound of hydraulic gurneys being unloaded, the short, clipped communications between emergency medical technicians and hospital staff. 7 ambulances in 12 minutes, which meant the initial casualty reports had been conservative. This was a mass casualty event that would strain the hospital's resources and test the emergency response protocols that most of the staff had, hopefully, never needed to use under real conditions. Casey abandoned her parallel bar exercises and walked toward the emergency department, moving as quickly as her reconstructed leg would allow. She told herself she was just curious, just responding to the natural human impulse to understand what was happening during a crisis. but her subconscious was already shifting into a mode of thinking that had nothing to do with curiosity and everything to do with the kind of professional assessment that had once been her primary responsibility. The emergency department was a carefully orchestrated symphony of medical professionals doing what they'd been trained to do under pressure. Triage nurses were rapidly assessing incoming patients, assigning priority levels based on the severity of injuries and the likelihood of successful treatment. Doctors were moving between examination rooms, making quick decisions about resource allocation and treatment protocols. Support staff were managing the flow of information and equipment that kept the entire system functioning. But Casey could see the stress points developing. Too many critical cases arriving simultaneously. Not enough trauma surgeons immediately available for the patients who needed emergency surgery. A bottleneck forming in the imaging department where patients were waiting for CT scans and X-rays that would determine their treatment priorities. She positioned herself near the edge of the emergency department where she could observe without interfering, her trained eye automatically cataloging the injuries she could see and the resources being deployed to address them. Multiple orthopedic trauma cases, several patients with potential internal bleeding, at least 2 with obvious traumatic brain injuries that would require immediate neurosurgical consultation. It was then that Gabriel Santos noticed her. He'd been helping to transfer patients from ambulance gurneys to hospital beds when he saw Casey standing near the entrance to the emergency department. But this wasn't the quiet, unassuming patient he'd observed over the past 2 days. Her posture was different. Alert, focused, professionally assessing the situation unfolding around her. Her eyes were moving in a pattern he recognized, the systematic visual sweep that medical professionals use to rapidly triage multiple patients and identify the most critical cases. Gabriel approached her carefully, not wanting to startle her or interrupt what appeared to be an intense mental process. "Casey, are you all right?" She turned toward him, and Gabriel saw something in her expression that confirmed every suspicion he'd been developing about her background. Her eyes held the kind of focused intensity that came from seeing similar situations before, from knowing exactly what needed to happen next and having the training to make it happen. "How many critical cases?" she asked, her voice carrying an authority that was completely different from the patient voice he'd heard during her previous interactions with hospital staff. Gabriel blinked, surprised by the directness of the question and the professional tone in which it was delivered. 15 total patients, 7 critical. We've got 2 trauma surgeons on duty and 1 more coming in from home." Casey nodded, her mind clearly processing this information in ways that went beyond casual concern. "Anesthesiology coverage?"
2 anesthesiologists, but one of them is already in surgery with a case that started before the bus accident. Gabriel found himself responding to Casey's questions as if she were a colleague seeking operational information, rather than a patient who'd wandered into the emergency department during a crisis. There was something about her demeanor that commanded professional respect, that made her inquiries seem legitimate rather than intrusive. "Casey," Gabriel said carefully, "what's your medical background?" She looked at him for a long moment, and Gabriel could see her weighing how much she was willing to reveal. The crisis unfolding around them seemed to be pushing against her natural inclination toward privacy, forcing her to consider whether her expertise might be needed more than her anonymity. "Army Special Forces medic," she said finally, 18 Delta. 6 deployments, 3 years as a trauma team leader at a forward surgical team in Afghanistan. Gabriel felt his breath catch. 18 Delta was the military occupational specialty for Special Forces medical sergeants, the most highly trained combat medics in the U.S. military. These were the soldiers who provided emergency medical care for special operations units operating in remote locations where traditional medical support wasn't available. Their training was equivalent to position assistance in many respects, with additional specialization in trauma surgery and emergency procedures that most civilian medical professionals never encountered. "Your call sign?" Gabriel asked, though he suspected he already knew why her medical records had been so carefully sanitized. "Compass," Casey replied, and Gabriel recognized the weight that simple word carried. Compass wasn't just a call sign, it was a reputation. Gabriel had heard stories during his training about a special forces medic who'd become legendary for her ability to stabilize critically wounded soldiers under impossible conditions, who'd performed emergency surgeries in situations where the casualty should have died long before reaching a proper medical facility. "Jesus," Gabriel whispered, "you're her. You're the medic who saved those Rangers at Firebase Charlie?" Casey's expression tightened. Firebase Charlie was classified, an operation that officially never happened, in a location that didn't appear on any maps. The fact that Gabriel knew enough to reference it meant he'd been exposed to information that was available only to people with specific clearances and operational need to know. "How do you know about that?" she asked. "Advanced combat medic training. They used your techniques as case studies, never used your real name, but the scenarios were based on your field reports. You revolutionized emergency thoracic surgery for combat medics." Around them, the emergency department continued its urgent work, but Gabriel and Casey were locked in a conversation that was redefining everything Gabriel thought he knew about the quiet woman who'd been dismissed by his colleagues as just another patient with internet-educated opinions about her medical care. "Gabriel," Casey said carefully, "I need you to get me to Dr. Hayes or whoever's running this response. That patient on gurney 3 has tension pneumothorax that's been missed. His trachea is deviating and his oxygen saturation is dropping. He needs immediate needle decompression or he's going to arrest in the next 5 minutes." Gabriel looked toward gurney 3 and saw exactly what Casey was describing, a patient whose condition was deteriorating rapidly, while the medical team focused on more obvious injuries. Casey's assessment was accurate, professional, and based on the kind of rapid diagnostic skills that could only come from extensive experience with similar cases. "I'll get Dr. Hayes," Gabriel said, understanding that the quiet phase of Casey Monroe's civilian life was about to end. "But Casey, why didn't you tell anyone who you were?" Casey looked around the emergency department at the controlled chaos that was so familiar and yet so different from the field hospitals where she had spent the most important years of her professional life. "Because sometimes it's easier to let people see what they expect to see. But right now, that patient needs help, and I'm the most qualified person in this room to provide it." Gabriel nodded and hurried toward the trauma bay where Dr. Hayes was coordinating the response to the mass casualty event. Behind him, Casey moved toward gurney 3 with the purposeful stride of someone who just remembered exactly who she was and what she was capable of doing when lives hung in the balance. The revelation was complete. Now came the demonstration that would prove whether her legendary reputation was deserved or simply the product of military mythology and classified storytelling. In the next few minutes, everyone at Naval Hospital Camp Pendleton was about to learn the difference between credentials and capability, between assumption and expertise, between the person they thought Casey Monroe was and the warrior healer she'd always been.
Gabriel found Dr. Elizabeth Hayes in Trauma Bay 2, where she was coordinating the surgical response to the mass casualty event with the kind of controlled urgency that emergency medicine demanded. Her hands moved efficiently as she examined a patient with multiple fractures, her voice calm and authoritative as she directed the trauma team through assessment and stabilization procedures. "Dr. Hayes," Gabriel called out, his voice cutting through the organized chaos of the emergency department. "I need to speak with you immediately. It's about Casey Monroe." Dr. Hayes looked up from her patient, irritation flashing across her face. The last thing she needed during a mass casualty response was to deal with administrative issues about routine orthopedic patients. "Gabriel, whatever it is, it needs to wait. We have 15 trauma patients and—" "Doctor, she's not who we thought she was," Gabriel interrupted, his voice carrying enough urgency to make Dr. Hayes pause in her examination. "Casey Monroe is an 18 Delta, Special Forces medic. Her call sign was Compass." The significance of that information hit Dr. Hayes immediately. Every military medical professional knew about the legendary Special Operations medics, the soldiers whose training surpassed most civilian emergency medicine physicians in specific areas of trauma care. And if Gabriel was right about Casey's identity, then the woman who'd been dismissed as an internet-educated patient was actually one of the most highly trained combat medics in military history. "Are you certain about this?" Dr. Hayes asked, her attention now fully focused on Gabriel despite the ongoing crisis around them. "She identified a tension pneumothorax that we missed,"
Gabriel replied. Patient on gurney 3. She says he needs immediate needle decompression or he's going to arrest. Dr. Hayes turned toward gurney 3, where a patient was indeed showing signs of respiratory distress that had been overlooked in the initial triage process. The patient's oxygen saturation was dropping, her trachea was deviating slightly to the left, and her chest expansion was asymmetrical, all classic signs of tension pneumothorax that required immediate intervention. Jesus, Dr. Hayes breathed, realizing that Casey's assessment was not only accurate, but potentially life-saving. Where is she now? Gabriel pointed toward the edge of the trauma bay where Casey stood, her posture alert and professional as she continued to observe the medical response. But she wasn't simply watching. She was conducting a systematic assessment of the entire emergency department, cataloging resources and identifying inefficiencies with the kind of operational awareness that came from managing medical crises in combat zones. Dr. Hayes approached Casey with a mixture of professional respect and personal embarrassment. Less than 24 hours earlier, she'd dismissed this woman's medical knowledge as internet-educated patient and amateur presumption. Now she was confronting the possibility that she'd been condescending to someone whose expertise in trauma medicine exceeded her own. Ms. Monreal, then she caught herself. I'm sorry, what's your preferred title? Casey is fine, but that man is going to die if someone doesn't decompress his chest in the next 3 minutes. Dr. Hayes nodded and immediately moved toward gurney 3, calling for the necessary equipment while directing her team to prepare for an emergency needle thoracostomy. As she worked, she was acutely aware that Casey was observing her technique, assessing her competence in the same way she'd been assessed during medical school and residency training. The procedure was successful and the patient's condition stabilized immediately. Color returned to his face, his oxygen saturation improved, and the asymmetrical chest movement resolved as the trapped air was released from his pleural cavity. It was a textbook save, the kind of intervention that separated life from death in emergency medicine. How did you spot that? Dr. Hayes asked as she completed the procedure. Casey's response was matter-of-fact, delivered with the kind of professional detachment that came from years of making similar observations under pressure. Subtle tracheal deviation, decreased breath sounds on the right side, and the way he was positioning himself to compensate for restricted chest expansion. I've seen it before. How many times? Enough to recognize it instantly. Dr. Hayes understood that Casey's clinical experience had been forged in environments where missing a diagnosis like tension pneumothorax meant the difference between a soldier returning home and a family receiving a folded flag. Her diagnostic skills had been sharpened by stakes that civilian emergency medicine rarely encountered. Casey, Dr. Hayes said, her voice carrying the kind of professional respect that had been absent from their previous interactions, we need your help. This is the largest mass casualty event we've handled, and we're operating at the edge of our capacity. Your experience could save lives.
Casey looked around the emergency department, assessing the situation with the kind of systematic analysis she'd once applied to combat zones where resources were limited and decisions had to be made quickly. She could see the stress points developing. Too many critical cases, insufficient surgical resources, and coordination challenges that were slowing down the response. What do you need? She asked. Triage support. We have more patients coming in, and we need someone with your level of experience to help prioritize cases and identify the ones that are most likely to benefit from immediate intervention. Casey nodded, understanding that Dr. Hayes was asking her to step back into a role she thought she'd left behind forever. But the familiar weight of responsibility felt natural, comfortable even, like putting on a piece of clothing that fit perfectly after months of wearing things that never quite felt right. Give me a quick brief on your current capacity, Casey said, her voice caking on the authoritative tone that had once coordinated medical teams in forward operating bases. How many ORs are available? What's your anesthesiology coverage? And what's the ETA on additional surgical staff? Dr. Hayes provided the operational details with the efficiency of one professional briefing another. 2 operating rooms available, 1 anesthesiologist in surgery with a case that couldn't be interrupted, a second anesthesiologist handling the new trauma cases, and a third coming in from home with an estimated arrival time of 45 minutes. Casey processed this information while simultaneously observing the flow of patients and staff through the emergency department. She was seeing patterns and potential problems that her civilian colleagues were missing, identifying solutions that came from years of practicing medicine in environments where conventional resources weren't available. The patient in bed 7 has compartment syndrome developing in his left leg, Casey said, pointing toward a man whose lower extremity injury had been triaged as non-critical. His pain is disproportionate to the apparent injury, and I can see early signs of tissue swelling that indicates increased pressure. He needs fasciotomy within the next hour or he's going to lose the leg. Dr. Hayes looked toward bed 7 and realized that Casey was right. The patient had been classified as stable based on his initial presentation, but his condition was deteriorating in a way that required immediate surgical intervention. "I'll get him prepped for surgery," Dr. Hayes said, then paused. "Casey, would you consider scrubbing in? We could use your experience in the OR." The question hung in the air like a challenge and an opportunity simultaneously. Casey hadn't performed surgery since her medical retirement, hadn't even considered whether her skills remained sharp after months of civilian life and physical rehabilitation. But around her, the emergency department continued its urgent work, and she could see patients who needed the kind of expertise she'd spent years developing in places where failure wasn't an option. "I'm not licensed to practice in California," Casey said, the practical concern of a medical professional who understood liability and legal requirements. "We're operating under emergency protocols. Your military medical credentials and experience provide sufficient authorization under these circumstances. The question is whether you're ready to do this." Casey looked around the emergency department one more time, seeing the controlled chaos through the lens of someone who'd managed similar situations in forward surgical teams, where the stakes were life and death and the resources were whatever you could carry in a field medical kit. These patients needed help, and she had the training to provide it. "I'll need to see the patient files and understand the surgical priorities, and I'll need someone to assist who can adapt quickly to field surgical techniques." Dr. Hayes felt a surge of relief and professional excitement. She was about to witness surgical techniques that were developed in combat zones and refined through years of treating the most challenging trauma cases under impossible conditions. Casey Monroe's civilian persona was about to give way to Compass, the legendary Special Forces medic whose innovations had saved countless lives in places where conventional medicine couldn't reach. "Gabriel," Dr. Hayes called out, "prep OR3 for emergency compartment syndrome repair and get Ruby Patel for medical students. She's been asking for trauma surgery exposure, and I think she's about to get more than she bargained for." As Casey walked toward the surgical prep area, her limp was barely noticeable, her focus entirely concentrated on the medical challenges ahead. The quiet patient who'd been dismissed and condescended to was transforming back into the warrior healer whose reputation had been whispered about in military medical circles for years. The demonstration was about to begin, and everyone in the hospital was about to understand what real expertise looked like when lives depended on it.
Operating Room 3 at Naval Hospital Camp Pendleton had been transformed into a space that would have been familiar to Casey from her deployments in Afghanistan and Iraq. The patient with compartment syndrome lay prepped and draped on the surgical table, his left leg swollen with the kind of tissue pressure that could cause permanent damage within hours if left untreated. Ruby Patel, the medical student who'd caught Gabriel's attention days earlier, stood at the side of the table with the wide-eyed intensity of someone about to witness surgery that wasn't covered in any textbook. Casey approached the scrub sink with the methodical precision that had become second nature during her years in forward surgical teams. The familiar ritual of surgical preparation, the careful attention to sterile technique, the systematic cleansing that eliminated any possibility of contamination transported her back to operating rooms in field hospitals, where the margin for error was measured in lives lost or saved. Dr. Hayes stood opposite her at the scrub sink, and Casey could sense the mixture of professional curiosity and personal embarrassment that her colleague was carrying. Less than 24 hours earlier, Dr. Hayes had dismissed Casey's medical knowledge as amateur presumption. Now she was preparing to assist someone whose surgical experience had been forged in environments where conventional protocols were often improvised and success depended on innovation under pressure. "Have you performed many fasciotomies?" Dr. Hayes asked as they completed their surgical prep. "More than I'd like to remember," Casey replied, her voice carrying the weight of experience earned in places where compartment syndrome was a common complication of blast injuries and prolonged evacuation times. Most of them under conditions that would be considered substandard by civilian hospital standards. As they entered the OR, Casey's demeanor shifted in a way that was immediately noticeable to everyone in the room. The quiet, unassuming patient persona gave way to the focused intensity of a surgeon who'd learned to operate with absolute precision under impossible conditions. Her movements became economical, purposeful, with the kind of spatial awareness that came from working in cramped field hospitals where every inch of space mattered. Ruby Patel watched in fascination as Casey positioned herself at the surgical table. There was something different about her presence compared to the other surgeons Ruby had observed during her clinical rotations. Casey seemed to inhabit the space around the patient, rather than simply standing beside the table. Her awareness extended through her hands and instruments in a way that suggested complete integration with the surgical environment. "Ruby, you're going to see some techniques today that aren't typically taught in medical school. Field surgical methods developed for combat conditions, but adapted for civilian trauma care." Casey palpated the patient's leg, her fingers reading the tissue tension and swelling with the kind of diagnostic precision that could only come from treating hundreds of similar cases. The compartment syndrome was advanced, with tissue pressures that indicated irreversible damage would occur within the next 30 to 40 minutes if the condition wasn't immediately addressed. "Pressure readings?" Casey asked, having been assigned to monitor the compartment pressure measurements. 38 millimeters of mercury," Ruby replied. Casey nodded, understanding that the normal pressure should be less than 10 millimeters of mercury. At 38, the patient was well into the range where permanent tissue damage and loss of limb function were inevitable without immediate surgical intervention. "We're going to perform a 4-compartment fasciotomy," Casey announced, her hands already moving to position the patient's leg for optimal surgical access. "The technique I'm going to use was developed for battlefield conditions where surgical time needed to be minimized and tissue preservation maximized." What followed was a demonstration of surgical technique that none of the civilians in the operating room had ever witnessed. Casey's incisions were precise, economical, placed with the kind of strategic thinking that considered not only immediate tissue decompression, but also long-term functional recovery and cosmetic outcomes. Her movements were fluid, confident, with no wasted motion or unnecessary procedures. "Notice how she's releasing each compartment systematically," Dr. Hayes explained to Ruby, her voice carrying genuine admiration for the surgical skill she was witnessing. "The sequence is designed to maximize pressure relief while minimizing bleeding and tissue trauma." Casey worked with instruments in a way that suggested they were extensions of her hands rather than separate tools. Her scalpel moved through tissue layers with the kind of precision that came from understanding anatomy at a level that went beyond textbook knowledge. This was practical understanding, earned through years of treating complex trauma under conditions where surgical errors had immediate and irreversible consequences. "Casey, watch how she's releasing each compartment systematically," Casey said, her voice calm and instructional even as she worked. "In field conditions, you don't always have perfect visualization or optimal lighting. You learn to work by feel, understanding tissue resistance and anatomical landmarks through tactile feedback." As she opened each compartment, the trapped tissue pressure was released with immediate and visible results. Swollen muscle tissue that had been compressed and ischemic began to regain normal color and perfusion. The patient's vital signs stabilized as his body's physiological stress response diminished. "Bleeding?" Dr. Hayes asked, noting that Casey's technique was producing significantly less hemorrhage than she would have expected from such extensive surgical incisions. Field surgical technique emphasizes hemostatic control, Casey explained, her hands continuing their precise work. When you're operating in environments where blood products aren't readily available, you develop methods for minimizing blood loss while still achieving complete surgical objectives. Ruby watched in amazement as Casey completed the fasciotomy with a combination of speed and precision that defied everything she'd learned about the careful, methodical pace that civilian surgery typically required. This wasn't reckless or careless. It was surgical efficiency, refined by years of operating under time constraints where delays could mean the difference between saving a limb and performing an amputation. Time from incision to completion? Dr. Hayes asked, genuinely curious about Casey's surgical speed. 18 minutes, Ruby replied, checking the OR clock in disbelief. Most fasciotomies take at least 45 minutes to an hour. Casey began the closure process, and here again, her technique differed from standard civilian practice. Her suturing was rapid but meticulous, designed to provide optimal wound healing while minimizing the time the patient spent under anesthesia and the risk of surgical complications. In combat medicine, Casey explained as she worked, surgical speed isn't about showing off or cutting corners. It's about recognizing that every minute a patient spends on the operating table is a minute they're vulnerable to complications, blood loss, and physiological stress. You learn to achieve the same surgical outcomes in less time, which ultimately improves patient survival rates. As Casey completed the final sutures, the transformation in the patient's condition was dramatic and immediate. The swelling in his leg had decreased noticeably, his circulation had been restored, and the tissue that had been threatened with permanent damage now showed signs of healthy perfusion and viability. "That was incredible," Ruby said, her voice filled with the kind of awe that came from witnessing surgical skill that exceeded anything she'd imagined possible. "I've never seen compartment syndrome treated so effectively."
Dr. Hayes nodded in agreement, understanding that she just witnessed surgical techniques that were developed in the crucible of combat medicine and refined through years of treating the most challenging trauma cases under impossible conditions. Casey's reputation as Compass wasn't the product of military mythology. It was based on demonstrable surgical excellence that surpassed most civilian trauma surgeons. "Casey," Dr. Hayes said as they completed the post-surgical procedures, "that was extraordinary. Your techniques could revolutionize how we approach compartment syndrome treatment in civilian settings." Casey removed her surgical gloves with the same methodical precision she'd used throughout the operation. Field surgical techniques are designed to achieve optimal outcomes under suboptimal conditions. When you apply them in well-equipped civilian hospitals, the results can be even better than what's possible in combat zones. Around the operating room, the staff who'd observed the surgery were processing what they'd witnessed. This wasn't just competent surgical care, it was surgical excellence that redefined their understanding of what was possible in trauma medicine. The quiet woman who'd been dismissed as an internet-educated patient had just demonstrated skills that most of them would never achieve despite years of training and practice. "Is the patient stable for recovery?" Casey asked, her attention now focused on post-operative care and long-term rehabilitation planning. "Vitals are excellent," the anesthesiologist replied. "Better than we would normally expect after this type of surgery." His response to the procedure has been remarkable. Casey nodded, understanding that the patient's positive response was partly due to the minimally invasive techniques she'd used and the speed with which the compartment syndrome had been addressed. In her experience, rapid intervention with precise surgical technique typically produced better outcomes than delayed treatment with conventional methods. As they left the operating room, Casey's transformation back to her civilian persona was gradual but noticeable. The commanding presence that had dominated the surgical suite began to fade, replaced by the quiet, unassuming demeanor that had characterized her interactions with the hospital staff over the previous days. But everyone who'd witnessed the surgery understood that they'd seen something extraordinary. The woman laid underestimated and dismissed had just demonstrated surgical expertise that would be talked about in medical circles for years to come. Casey Monroe wasn't just a patient recovering from her own injuries.
She was a master surgeon whose skills had been forged in the most demanding medical environments imaginable. The demonstration was complete, and the reverberations would extend far beyond Operating Room 3 at Naval Hospital Camp Pendleton.
Word of what had happened in Operating Room 3 spread through Naval Hospital Camp Pendleton with the speed and intensity that only extraordinary events could generate. Within an hour of Casey's surgery, every department in the hospital had heard some version of the story. The quiet patient who'd been dismissed by the medical staff was actually a legendary Special Forces medic whose surgical skills exceeded those of most civilian trauma surgeons. Dr. Elizabeth Hayes sat in her office staring at the post-operative report she'd just completed. The clinical language of medical documentation seemed inadequate to capture what she'd witnessed during Tacy's fasciotomy. The surgical technique, the speed of execution, the innovative approaches to tissue preservation, all of it represented a level of medical expertise that challenged her understanding of what was possible in trauma surgery. But more troubling than her professional amazement was the personal reckoning she was facing. Less than 24 hours earlier, she'd condescendingly dismissed Casey's medical knowledge as internet research and amateur presumption. She'd treated someone with advanced surgical training as if she were a naive patient who'd overestimated her ability to understand complex medical concepts. The memory of that interaction now felt like a lead weight in her chest. There was a knock on her office door, and Olivia Wright entered with the hesitant expression of someone who knew she was about to have an uncomfortable conversation. Olivia had heard about the surgery from 3 different sources, each account more incredulous than the last, and she needed to understand what had really happened. "Dr. Hayes," Olivia said, settling into the chair across from the desk, "is it true about Casey Monroe that she's some kind of military surgical expert?" Dr. Hayes looked up from her computer screen, her expression carrying the weight of professional embarrassment and personal reflection. "Special Forces medic, call sign Compass. Her surgical training was equivalent to what we'd expect from a trauma surgery fellow, but with additional specialization in field medicine and emergency procedures." "But she never said anything," Olivia protested, as if Casey's failure to announce her credentials somehow absolved the staff of their dismissive treatment. "She just sat there while we talked about her like she was some kind of amateur." "She didn't owe us an explanation of her background," Dr. Hayes replied, understanding now that Casey's quiet dignity had been a response to our assumptions rather than confirmation of our assessments. "We made judgments about her competence based on her appearance and status as a patient, not on any actual evidence about her knowledge or capabilities." Derek Johnson appeared in the doorway, his usual confident demeanor replaced by the uncomfortable expression of someone who'd realized he'd made a significant error in judgment. He'd been cleaning the orthopedic wing when news of Casey's surgery reached him, and the revelation had shaken his understanding of the interactions he'd had with her over the past several days. "Dr. Hayes," Derek said, his voice lacking the casual authority it normally carried, "I heard about what happened in the OR, about Casey Monroe. I think I owe her an apology." Dr. Hayes gestured for Derek to enter the office, understanding that they were all going to need to process their individual roles in the systematic dismissal of someone whose expertise far exceeded their own. "What specifically do you think you need to apologize for, Derek?"
Derek shifted uncomfortably, remembering his lecture about leaving medical diagnoses to the professionals and his assumption that Casey's interest in medical literature was presumptuous rather than informed. "I talked to her like she was ignorant, made comments about how patients shouldn't try to understand medical concepts beyond their education level. Meanwhile, she probably knew more about trauma medicine than anyone in this hospital." "She did know more," Dr. Hayes confirmed. "Her surgical technique was the most advanced I've ever witnessed. She completed a complex fasciotomy in less than 20 minutes, with better outcomes than I would have achieved in twice the time." Olivia leaned back in her chair, processing the implications of what Dr. Hayes was telling them.
So when she was reading that book about Ebola, when she asked about those rehabilitation techniques, when she seemed interested in medical procedures, she was demonstrating knowledge that came from professional experience, not casual curiosity, Dr. Hayes finished. We interpreted her expertise as presumption because we couldn't see past our assumptions about who she was supposed to be. The conversation was interrupted by Gabriel Santos, who'd been looking for Dr. Hayes to discuss the post-operative care plan for the fasciotomy patient. Gabriel had spent the past hour researching everything he could find about Special Forces medical training, trying to understand the background that had produced the surgical excellence he'd witnessed. Dr. Hayes, Gabriel said, I've been reading about 18 Delta training. Did you know that Special Forces medics receive more advanced trauma surgery training than most civilian emergency medicine residents? Their field surgical protocols are designed to achieve outcomes that are considered impossible under normal circumstances. I'm beginning to understand that, Dr. Hayes replied. What I'm struggling with is how we missed it so completely. How did we fail to recognize that level of expertise? Gabriel had been thinking about this question since Casey's identity was revealed, and he had theories about the cognitive biases that had blinded them to her capabilities. I think we saw what we expected to see based on context rather than evidence. Patient in civilian clothes with a disability claim equals amateur medical knowledge. We never looked beyond those surface indicators to assess her actual competence. It's more than that, Derek said, his voice carrying the weight of someone who was beginning to understand his own prejudices. She's a woman. She was quiet. She didn't demand attention or respect. We assumed that someone with real expertise would announce themselves, would correct us when we made wrong assumptions about their background. Olivia nodded, recognizing the truth in Derek's observation. She sat there patiently while we talked down to her, while we explained medical concepts she understood better than we did. She never once made us feel stupid for underestimating her, even though she had every right to. Dr. Hayes stood up and walked to her office window, which looked out over the parking lot where Casey had sat in her car after being dismissed from her appointment. The question now is what we do with this knowledge. How do we learn from our mistakes and ensure we don't make similar assumptions about other patients?
Gabriel had been thinking about this as well, understanding that Casey's case revealed systemic issues in how medical professionals assessed patient knowledge and credibility. We need to change how we interact with patients who demonstrate medical understanding. Instead of assuming they're overreaching, we should explore the source of their knowledge and consider how it might inform their care. What about Casey herself? Olivia asked. Does she know how we treated her? Does she understand that we had no idea who she was? She understood exactly what was happening, Dr. Hayes replied, remembering the patient expression Casey had maintained during their dismissive interactions. She chose not to correct our assumptions, but that doesn't mean she wasn't aware of them. Derek leaned forward, his expression serious. Do you think she'll file a complaint, report our unprofessional behavior to hospital administration? Dr. Hayes considered this possibility, but her interaction with Casey during the surgery suggested someone who was more interested in helping patients than seeking retribution for personal slights. That's not my impression of her character, but that doesn't mean there won't be consequences for how we handled this situation. As is summoned by their conversation, Ruby Patel appeared in the doorway with the wide-eyed expression of someone who just witnessed something that challenged everything she thought she knew about medicine and professional expertise. Dr. Hayes, Ruby said, her voice filled with excitement and confusion. I just spent 3 hours in the library researching Special Forces medical training. Did you know that they're taught surgical procedures that aren't covered in most medical school curricula? That their success rates for complex trauma cases exceed civilian hospital statistics? We're beginning to understand that, Ruby, Dr. Hayes replied. What's your take on what happened today? Ruby entered the office and sat down, her expression serious, despite her obvious excitement about what she'd learned. I think we just witnessed surgical expertise that's going to change how I think about trauma medicine for the rest of my career. But I also think we need to talk about why none of us recognized her competence before today. What do you mean? Gabriel asked, though he suspected he knew where Ruby was heading. I mean that Casey Monroe displayed indicators of advanced medical knowledge from the moment she walked into this hospital. Her questions were too sophisticated, her observations were too precise, her behavior patterns were too consistent with someone who had professional medical training. We missed all of it because we were looking at her through the lens of our assumptions rather than actually listening to what she was telling us. Dr. Hayes nodded, understanding that Ruby had identified the core issue underlying their collective failure to recognize Casey's expertise. You're right. The evidence was there, but we chose to interpret it in ways that confirmed our preconceptions rather than challenging them. So, what do we do now? Derek asked. How do we make sure this doesn't happen again? The question hung in the air like a challenge and an opportunity simultaneously. They'd all been part of a systematic failure to recognize excellence in an unexpected form, and now they needed to figure out how to learn from that failure and become better medical professionals as a result. Outside Dr. Hayes' office window, the afternoon sun was beginning its descent toward the western mountains, and somewhere in the hospital, Casey Monroe was probably checking on her surgical patient and planning her return to the quiet civilian life she'd built for herself after leaving the world where her expertise had been valued and respected. But the reverberations of her brief return to surgery were just beginning, and everyone who'd witnessed her demonstration of surgical excellence was going to carry that memory with them for the rest of their careers.
3 weeks after Casey Monroe's surgical demonstration, Naval Hospital Camp Pendleton looked the same from the outside, but fundamental changes were taking place within its walls. The mass casualty event had become a catalyst for institutional reflection and reform, with Casey's revelation serving as the focal point for discussions about professional assumptions, patient assessment, and the recognition of expertise in unexpected forms. Dr. Margaret Cross, the hospital's chief of staff, sat in the main conference room reviewing the after-action report from the bus accident response. The clinical outcomes had been exceptional. All 15 trauma patients had survived, with recovery times that exceeded normal expectations for their injury severity. But what interested Dr. Cross more than the medical statistics was the detailed account of how a retired Special Forces medic had been systematically underestimated by the hospital staff until a crisis forced the recognition of her extraordinary capabilities. Dr. Hayes, Dr. Cross said, looking across the conference table at the orthopedic surgeon who'd written the most comprehensive section of the report, your recommendations for policy changes are extensive. Walk me through your rationale. Dr. Hayes had spent considerable time over the past 3 weeks reflecting on the Casey Monroe incident, and her recommendations represented a fundamental rethinking of how the hospital approached patient interactions and assessment of medical knowledge. Chief, we have a systemic problem with cognitive bias that affects how we evaluate patient competence and credibility. The Monroe case revealed that our staff consistently made assumptions about patient knowledge based on appearance, demeanor, and status rather than evidence. Specifically, we dismissed advanced medical knowledge as internet research. We interpreted professional expertise as amateur presumption, and we failed to recognize indicators of significant medical training because they didn't fit our expectations about how such expertise should present itself. Dr. Cross nodded, understanding that the Casey Monroe incident had exposed issues that extended far beyond one patient's treatment. What are you proposing? First, mandatory training for all clinical staff on unconscious bias and professional assumption. Second, new protocols for assessing patient medical knowledge that focus on content rather than context. Third, establishment of a veteran expertise recognition program that identifies patients with significant military medical training and ensures their knowledge is appropriately utilized. Gabriel Santos, who'd been invited to the meeting as the staff member who'd first recognized Casey's true background, added his own observations. Chief, We also need to address the cultural issues that prevented multiple staff members from seeing what should have been obvious indicators of advanced medical training. The problem wasn't just individual bias, it was institutional blind spots that affected our entire approach to patient assessment. Dr. Cross turned to Ruby Patel, whose perspective as a medical student provided insight into how these issues affected medical education and professional development. Ruby, how do you think this incident should influence our training programs? Ruby had been thinking about this question since witnessing Casey's surgery, and her answer reflected the kind of thoughtful analysis that had impressed her supervisors throughout her clinical rotations. I think we need to teach students to recognize expertise wherever it appears, regardless of context or presentation. Casey Monroe displayed indicators of advanced medical knowledge from her first day in the hospital, but none of us were trained to identify and value those indicators.
What kind of indicators? Sophisticated medical vocabulary used naturally rather than self-consciously. Questions about treatment protocols that revealed understanding of underlying physiological principles. Observational skills that suggested diagnostic experience. Body language and spatial awareness consistent with medical professional training. Dr. Cross made notes as Ruby spoke, understanding that the medical student's observations represented the kind of detailed analysis that could inform systematic improvements in patient care and staff training. Dr. Hayes, has Ms. Monroe provided any feedback about her experience here? Dr. Hayes had been hoping to avoid this question, but she knew it was central to understanding how the hospital's failures had affected the patient who'd been most directly impacted by them. She hasn't filed any formal complaints, but I think it's important to acknowledge that her experience here was characterized by consistent dismissal and condescension from multiple staff members who failed to recognize her expertise. Have you spoken with her directly about this? Briefly, during the post-operative discussion after her surgery, she was professional and focused on patient care, but it was clear that she'd been aware of our assumptions about her competence throughout her interactions with the hospital staff. Gabriel leaned forward, his expression serious.
Chief, I think it's important to understand that Casey Monroe handled our professional failures with remarkable grace. A lesser person might have made this a much bigger issue, might have used our ignorance to embarrass the hospital or advance their own interests. Instead, she focused on helping patients and demonstrating excellence rather than seeking recognition or retribution. Dr. Cross had been reviewing Casey's entire interaction history with the hospital, and Gabriel's assessment was consistent with everything she'd observed about the retired medic's character. That's consistent with what I've seen in her records. Even when she was being dismissed and condescended to, she maintained professional dignity and continued to engage constructively with her own medical care. Which makes our failure to recognize her expertise even more problematic, Dr. Hayes added. We weren't just dealing with someone who was demanding recognition or making unreasonable claims about their medical knowledge. We were dealing with someone who demonstrated advanced understanding through her questions, observations, and behavior, and we chose to dismiss those indicators rather than exploring them. Dr. Cross stood up and walked to the whiteboard where she began outlining the key elements of the policy changes they'd been discussing. Based on this conversation, I'm implementing several immediate changes. First, all clinical staff will complete bias recognition training within 60 days. Second, we're establishing new protocols for assessing patient medical background that emphasize evidence over assumption. Third, we're creating a veteran medical expertise database that identifies patients with significant military medical training. Ruby raised her hand tentatively. Chief, what about Casey Monroe specifically? Are we going to acknowledge our mistakes to her directly? The question hung in the air with particular weight, because everyone in the room understood that their professional failures had personally affected someone who deserved better treatment from the medical institution she'd come to for care. I think that's exactly what we need to do. But more than just acknowledging our mistakes,
I think we need to explore whether she might be interested in sharing her expertise with our staff on an ongoing basis. Gabriel's eyes lit up with interest. You mean like consulting or teaching? I mean, recognizing that we have access to someone whose surgical and trauma medicine expertise exceeds most of our senior staff, and finding ways to learn from that expertise rather than continuing to waste it through institutional blind spots.
Dr. Hayes had been thinking along similar lines, understanding that Casey's knowledge represented a resource that could benefit both the hospital and the broader medical community if it were properly recognized and utilized. She mentioned during our surgery that field surgical techniques could revolutionize civilian trauma care. What if we invited her to develop training programs based on her special operations medical experience? That's exactly what I'm thinking, Dr. Cross confirmed. But first, we need to address our institutional failures directly and honestly. We owe her an apology, but more importantly, we owe her the kind of professional respect and recognition that should have been extended from her first day in this hospital. Derek Johnson, who'd been quietly listening to the conversation, finally spoke up. Chief, I think I speak for a lot of the support staff when I say that we learned something important from this situation. We saw how our assumptions about people can blind us to their actual capabilities, and we saw how someone with real expertise handles being underestimated. Casey Monroe taught us about professionalism and dignity just by the way she carried herself through our ignorance. Dr. Cross nodded, understanding that the Casey Monroe incident had provided learning opportunities that extended far beyond medical training and into basic professional competence and human respect. Derek, that's an important observation. This situation revealed character differences as well as professional expertise differences. We saw what real excellence looks like, and we saw how it responds to being dismissed and underestimated. As the meeting continued, the participants developed a comprehensive plan for addressing both the immediate institutional changes needed and the longer-term cultural shifts that would prevent similar failures in the future. But underlying all their discussions was the recognition that they'd been privileged to encounter someone whose expertise and character far exceeded their initial assessments, and whose patient dignity had provided them with an opportunity to learn and grow rather than simply being embarrassed by their mistakes. One final question, Dr. Cross said as the meeting began to wind down. Do we have any information about Casey Monroe's current status? Is she still in the area? Is she still receiving treatment here? Gabriel had been wondering about this as well, understanding that Casey's demonstration of surgical excellence had raised questions about her transition to civilian life and her ongoing relationship with the military medical community. She completed her physical therapy program last week. Her final appointment was with Sandra Martinez, and according to Sandra's notes, her recovery has exceeded all projected timelines for her injury severity. So she's medically cleared for full activity? According to her final evaluation, yes. Her reconstructed leg has achieved full range of motion and strength. She's been released from ongoing medical care. Dr. Cross made a note of this information, understanding that Casey's medical clearance opened up possibilities for professional engagement that hadn't been available while she was still a patient receiving treatment. Then our next step is to reach out to her directly, acknowledge our institutional failures, and explore whether she might be interested in sharing her expertise with our staff in a more formal capacity. As the participants left the conference room, they carried with them the understanding that the Casey Monroe incident had been more than just a case study in professional assumptions and cognitive bias. It had been an encounter with excellence that had challenged their understanding of expertise, competence, and the ways that institutional blind spots could prevent them from recognizing and valuing the extraordinary people who sometimes walked quietly through their doors. The changes they were implementing would ensure that future Casey Monroes wouldn't be dismissed and underestimated, but would be recognized and valued for the knowledge and expertise they brought to the medical community. It was a lesson learned at the cost of professional embarrassment, but it was a lesson that would benefit countless patients and medical professionals in the years to come.
6 months after the bus accident that changed everything at Naval Hospital Camp Pendleton, Casey Monroe stood in the same conference room where Dr. Cross had implemented the policy changes that now bore her unofficial name. The Monroe protocols had become standard procedure throughout the military medical system, establishing new guidelines for recognizing and utilizing veteran medical expertise in civilian healthcare settings. But Casey wasn't there as a patient anymore. She wore the simple business attire of a civilian contractor, her posture carrying the quiet confidence that had always marked her interactions with the medical world. On the table in front of her lay a thick folder containing the curriculum she'd developed for the Combat Medicine Integration Program, a training initiative that would teach civilian medical professionals the field surgical techniques she'd refined during her years with special operations units. Dr. Elizabeth Hayes sat across from Casey, and the dynamic between them had fundamentally shifted from their first encounter 6 months earlier. Where there had once been condescension and dismissal, there was now professional respect and genuine collaboration. Dr. Hayes had become one of the most vocal advocates for Casey's training programs, having witnessed firsthand how combat medical techniques could revolutionize civilian trauma care. "The pilot program results are extraordinary," Dr. Hayes said, reviewing the data from the first group of surgeons who'd completed Casey's field surgical training. Average operative times reduced by 30%, complication rates down 15%, and patient satisfaction scores that exceed anything we've achieved with conventional techniques. Casey nodded, but her expression remained focused on practical implementation rather than celebration of early successes. "The techniques work because they're designed to achieve optimal outcomes under suboptimal conditions. When you apply those same principles in well-equipped civilian hospitals, the results are naturally going to be improved." Gabriel Santos, now serving as the liaison between Casey's training programs and the hospital's continuing education department, had been documenting the broader impact of the Monroe protocols throughout the military medical system. "Casey, we're getting requests from 17 different hospitals to implement your training programs. The demand is exceeding our capacity to deliver the instruction." "That's a good problem to have, but we need to be careful about scaling too quickly. These techniques require hands-on instruction and careful supervision during the learning process. We can't compromise quality for quantity." Ruby Patel, who'd completed her medical degree and was now beginning her residency in trauma surgery, had become one of Casey's most dedicated students. The surgical techniques she'd learned from Casey had already set her apart from other residents, and she'd been accepted into a competitive trauma surgery fellowship that would allow her to further develop her expertise in combat medical applications. "Casey, I've been thinking about the long-term implications of your training programs. We're not just learning surgical techniques, we're learning a different approach to medical problem solving that emphasizes adaptability and resource optimization." Casey had been thinking about this as well, understanding that her training programs were transferring more than just technical skills. They were teaching medical professionals to think differently about challenges, to find solutions under pressure, and to maintain composure when conventional approaches weren't available. "That's the most important part," Casey confirmed. "Technical skills can be taught to anyone with sufficient practice. But the mindset that allows you to adapt those skills to unexpected situations, that comes from understanding principles rather than just memorizing procedures." Dr. Margaret Cross had been observing the conversation with the satisfaction of someone who'd witnessed an institutional transformation that exceeded her most optimistic expectations. The Casey Monroe incident had catalyzed changes that improved patient care, enhanced staff training, and established the hospital as a leader in military-civilian medical collaboration.
"Casey," Dr. Cross said, "I want to discuss the offer from the Department of Defense. They're interested in having you develop these training programs on a national scale." Casey had been expecting this conversation, understanding that the success of her programs at Camp Pendleton would inevitably lead to opportunities for broader implementation. But she'd also been thinking carefully about the implications of returning to a more formal relationship with the military medical system she'd left behind. "I'm interested in expanding the programs," Casey said. But I want to maintain the flexibility to focus on practical training rather than bureaucratic administration. The techniques work because they're taught by people who've actually used them under real conditions, not because they're endorsed by official organizations. Gabriel leaned forward, understanding Casey's concerns about maintaining the integrity of her training while expanding its reach. What if we structured it so that you train instructors rather than trying to personally deliver all the programs? Create a cadre of qualified trainers who can maintain your standards while expanding capacity. Casey considered this proposal, recognizing its potential for sustainable growth while preserving the quality control that was essential to the program's effectiveness. That could work, but we'd need rigorous certification standards and ongoing quality assessments to ensure the training remains consistent with field-tested methods. The conversation continued for another hour, covering the practical details of program expansion, certification requirements, and the long-term vision for integrating combat medical techniques into civilian healthcare. But underlying all their discussions was the recognition that Casey's journey from dismissed patient to respected instructor represented something larger than individual professional achievement. Derek Johnson, who'd completed Casey's bias recognition training and had become one of the hospital's most effective advocates for veteran patient dignity, knocked on the conference room door with an update that brought their planning session back to immediate practical concerns. "Casey," Derek said, "we've got a situation in the emergency department. Multi-vehicle accident with complex trauma cases, and Dr. Martinez is requesting your consultation on surgical approach." Casey stood up immediately, her civilian contractor persona giving way to the focused intensity that had characterized her response to medical emergencies throughout her career as a combat medic. "How many patients?" "4 critical, 2 stable. The critical cases include crush injuries and what appears to be traumatic amputation." Casey was already moving toward the door, her mind automatically shifting into operational mode that had served her throughout her years as a combat medic. "Gabriel, get Ruby and meet me in the ED. Dr. Hayes, can you coordinate with anesthesiology for multiple OR availability?" As they left the conference room, Dr. Cross watched Casey transform from program developer to emergency medical responder, understanding that the quiet woman who'd been dismissed 6 months earlier had evolved into someone whose expertise was now recognized and valued throughout the military medical community. But more than professional recognition, Casey had achieved something that had eluded her during the difficult transition from military to civilian life. She'd found a way to use her expertise in service of something larger than herself, to continue the mission of healing and helping that had defined her identity long before she'd earned the call sign Compass. In the emergency department, Casey worked alongside the medical professionals who'd once dismissed her knowledge, but now sought her guidance and valued her contributions. Ruby Patel assisted with the same eager attention she'd shown during that first fasciotomy 6 months ago, but now with the additional skills and confidence that came from months of training under Casey's instruction. Gabriel coordinated the response with the efficiency of someone who'd learned to recognize and utilize expertise wherever it appeared, regardless of its presentation or context. And Dr. Hayes performed surgery with techniques that had been refined in combat zones and adapted for civilian applications, achieving outcomes that exceeded what conventional methods could have accomplished.
When the emergency was over and all 4 critical patients had been stabilized and were recovering in the ICU, Casey found herself standing in the same parking lot where she'd sat in her car 6 months earlier, processing the dismissive treatment she'd received from medical professionals who couldn't see past their assumptions about her capabilities. But now the parking lot represented something different. Not the frustration of being underestimated, but the satisfaction of being valued for the expertise she'd spent years developing in service of her country and her fellow soldiers. The quiet civilian life she'd tried to build for herself had evolved into something more purposeful and meaningful, a continuation of her mission, rather than a retreat from it. Ruby Patel approached her as she prepared to leave,
her expression carrying the kind of professional respect and personal gratitude that reminded Casey why teaching and mentoring had become such an important part of her new role. "Casey," Ruby said, "thank you for everything you've taught me. Not just the surgical techniques, but the way you approach challenges and maintain focus under pressure. I'm going to carry those lessons with me throughout my career." Casey nodded, understanding that Ruby's gratitude represented more than individual appreciation. It represented the continuation of knowledge and expertise that would benefit countless patients in the years to come, the multiplication of impact that came from teaching others to excel rather than simply excelling yourself. "Remember," Casey said, "expertise isn't about credentials or recognition. It's about competence, dedication, and the willingness to serve something larger than yourself. Keep learning, keep growing, and never let anyone convince you that you don't belong in spaces where you can make a difference." As Ruby walked back toward the hospital, Casey reflected on the journey that had brought her from the dismissed patient who'd sat quietly while medical professionals explained why her knowledge was inadequate, to the respected instructor whose expertise was now sought throughout the military medical system. The journey hadn't been easy, and there had been moments when the weight of being constantly underestimated had made her question whether the transition to civilian life was worth the personal cost. But now, standing in the parking lot of Naval Hospital Camp Pendleton as the sun set over the California mountains, Casey understood that her service hadn't ended when she retired from active duty. It had simply evolved into a different form, one that honored her past achievements and her ongoing commitment to healing and helping others. The quiet dignity with which she'd endured months of dismissive treatment had been transformed into a platform for teaching and mentoring that would impact military medicine for generations to come. Her story had become more than personal vindication. It had become institutional change that would ensure other veterans with hidden expertise would be recognized and valued rather than dismissed and underestimated. As Casey drove away from the hospital, she carried with her the satisfaction of knowing that her expertise had found its proper place in the world, and that the lessons learned from her experience would prevent countless other stories of overlooked competence and wasted talent. The legacy wasn't just about surgical techniques or training programs. It was about the recognition that excellence appears in many forms, and that institutional wisdom begins with the humility to acknowledge expertise wherever it's found. Up next, you've got 2 more standout stories right on your screen. If this one hit the mark, you won't want to pass these up. Just click and check them out. And don't forget to subscribe and turn on the notification bell so you don't miss any upload from us.